Hey guys, in this video we will see parenteral anticoagulants, heparin and its derivatives, low molecular weight heparin and fondaparinux. Let's start with quick revision of relevant physiology first. In video of blood coagulation, we saw that intrinsic pathway of coagulation starts with activation of factor 12, which activates factor 11, which in turn activates factor 9. Factor 9 activates factor 10. Then starts the common pathway where factor 10 activates factor 2, also called prothrombin, into factor 2A or thrombin. Thrombin converts fibrinogen into fibrin monomer, which eventually leads to coagulation. Thrombin also contributes in activation of platelets for platelet plug formation. Arterial thrombi are rich in platelets and venous thrombi are rich in fibrin. Now endogenous anticoagulant factors. Here we have antithrombin 3 and heparin. Antithrombin 3 is a plasma protein released from liver. It is a suicide inhibitor of active factor 10, thrombin, factor 9, 11 and 12. Heparin is a mucopolysaccharide. Actually, under physiological condition, a similar mucopolysaccharide, heparan sulfate, is more important anticoagulant. But anyway, we want to study heparin today. It is present in mast cells and basophils. Richest source of heparin in our body are lung, liver and intestine. It does not have anticoagulant effect of its own. However, it accelerates action of antithrombin 3. That should be enough from physiology. Now we are ready to move to pharmacology of heparin. Commercial preparations of heparin are obtained from ox lung and pig intestinal mucosa. It is a non-uniform mixture of mucopolysaccharides with different molecular weights. The weight ranges from 5 kilodalton to 30 kilodalton, with average molecular weight of about 15 kilodalton. It is a strongly acidic drug. Now let's see the mechanism of action of heparin. It has no anticoagulant activity of its own. However, antithrombin 3 mediated inhibition of factor 10, thrombin, 9, 11 and 12 is facilitated by heparin. This is done by two mechanisms. 1. It binds with both antithrombin 3 as well as clotting factor. This brings them together to interact. And second, 1/3 of heparin molecules have a specific pentasaccharide sequence in their structure. It binds with antithrombin 3 and induces conformational changes in it. This exposes its active site, which can now easily inhibit clotting factor. Then heparin dissociates from this complex of antithrombin and clotting factor and help other antithrombin molecules. Although all these factors, including factor 9, 11 and 12 are inhibited, anticoagulant effect develops mainly due to inhibition of factor 10 and thrombin. Here, inhibition of factor 10 requires only one mechanism, that is, conformational changes in antithrombin 3 by this pentasaccharide sequence. Whereas thrombin needs both the mechanisms, that is, its binding with heparin in addition to the conformational changes. In unfractionated heparin, most of the heparin molecules are long enough to provide this binding facility, so they can accelerate inhibition of thrombin. However, in low molecular weight heparin that we are going to see later in this video, most of the molecules are not long enough to spare this binding space. So thrombin cannot bind with them and its inhibition is not accelerated by low molecular weight heparin. So low molecular weight heparin only accelerates inhibition of factor 10. I initially remembered this difference for factor 10 and thrombin like this. Factor 10 with number 1 in its name requires only one mechanism, so it's easy to inhibit it and all the drugs can do it. Whereas thrombin, also called factor 2, which is literally 2, requires two mechanisms, so it is difficult to inhibit it and only heparin molecules with large size can do it. Now as heparin interferes with factors of intrinsic pathway, APTT is prolonged. Whole blood clotting time is also prolonged, but PT is not affected much with heparin. Now antiplatelet effect of heparin. We have seen that apart from its role in coagulation, thrombin also contributes in platelet activation. So its inhibition by heparin produces antiplatelet effect also. Finally, heparin has lipemia clearing effect. Heparin causes release of lipoprotein lipase, which clears postprandial lipemic plasma. Now let's see the uses of heparin. We have seen that arterial thrombi are comparatively rich in platelets and venous thrombi are rich in fibrin. So in general, antiplatelets are more suitable for arterial thrombosis and anticoagulants are more suitable in venous thrombosis. Thus, anticoagulants like heparin and warfarin are preferred in venous conditions like deep vein thrombosis and pulmonary embolism. They are also used for prophylaxis of these conditions in high-risk patients like bedridden and old patients, postoperatively, and in patients with hip or leg fracture. They are also used in myocardial infarction, in unstable angina to reduce chance of infarction, rheumatic heart disease, retinal vessel thromboembolism, cardiovascular disease, disseminated intravascular coagulation, and in procedures like coronary balloon angioplasty, cardiac bypass surgery, prosthetic heart valves, extracorporeal circulation like hemodialysis, etc. Heparin molecules are large and highly ionized, so they do not cross the placenta. So heparin is preferred in pregnancy. When long-term anticoagulant therapy is required, usual strategy is to start both parenteral heparin and oral warfarin. Heparin starts working immediately and it is continued for 5 to 7 days. During this period, effect of warfarin gradually develops. Then heparin is discontinued and oral therapy with warfarin is continued as long as needed. Coming to pharmacokinetics, which is going to get interesting. First of all, USP units. As heparin molecules are of different size and weights, the dose of heparin is calculated in USP units rather than in grams. 1 USP unit is amount of heparin that prevents clotting of 1 ml of saturated sheep plasma after adding 0.2 ml of 1% CaCl2 for 1 hour. Now routes and absorption. As heparin molecules are large and highly ionized, they are not absorbed orally. Intramuscular injection causes hematoma. So these routes are out. It is given by intravenous or subcutaneous injection. By intravenous route, it is given bolus followed by continuous or intermittent infusion. With this route, it starts working immediately. Subcutaneously, it is given every 8 to 12 hours. Bioavailability is about 30% with this route, but it is not consistent and shows variation. Effect starts to develop about 1 hour after the injection. Moving to elimination. It occurs mainly by reticuloendothelial system. It is a saturable kinetic, so half-life of heparin increases with dose. It ranges from about 1 hour at 100 units per kilogram to about 5 hours at 800 units per kilogram dose. Now let's talk about heparin resistance. In this situation, patient does not respond to heparin and require very high dose to achieve therapeutic APTT, or sometimes it's not achieved at all. This can happen due to multiple reasons, like increased binding of heparin with plasma proteins. So enough heparin is not present in free form to work. Its increased clearance and deficiency of antithrombin 3 through which heparin works. These are the genuine reasons where heparin is not working enough and desired APTT is not achieved. Don't get misguided by apparent or pseudo-heparin resistance which occurs due to increased level of factor 8. It only alters the lab results of APTT, whereas in body heparin is working fine. Coming to the monitoring of heparin therapy. Because of the inconsistencies in its pharmacokinetic profile, like its inconsistent absorption through subcutaneous route, changing half-life with dose, and chances of resistance, heparin produces unpredictable response. So monitoring is required with heparin therapy, especially in the beginning. It is done by measuring APTT from time to time. First it is measured before starting the treatment to get a baseline value, and then it is maintained 1.5 to 2.5 times that baseline value during the treatment. Other options for monitoring are anti-factor 10A assay and whole blood clotting time. Low dose regimens like those used for prophylaxis of deep vein thrombosis do not alter APTT or whole blood clotting time. In such situation, monitoring is not required. Now let's move to the adverse events. First and foremost, bleeding due to inhibition of clotting factors. Hematuria is usually first to occur. In case of excessive bleeding, discontinuing heparin is usually enough. Because of short half-life, it is rapidly cleared from body. If needed, it can be treated with its specific antidote, protamine sulfate. It is strongly basic and neutralizes acidic heparin molecules weight to weight. It is commonly used when heparin action needs to be terminated rapidly, like during cardiac or vascular surgery. The dose of protamine sulfate should be just enough to neutralize heparin. If more than required dose is given, it interacts with platelet and fibrinogen and produces anticoagulant effect of its own. Now second adverse event, heparin-induced thrombocytopenia. It is an immune-mediated reaction. The story starts with activated platelets. Its alpha granules release a protein called platelet factor 4. It binds with heparin. Now, in some unfortunate patients, these complexes of heparin and platelet factor 4 initiate immune response and antibodies are produced against them. This occurs over the period of 5 to 10 days, and antibodies are of IgG type. These antibodies bind with these complexes. Now, circulating platelets have a receptor called Fc gamma 2a on their surface. It binds with this entire complex through Fc portion of the antibody. This causes platelet activation. Such activated platelets aggregate and cause thromboembolic events. Its manifestations are mainly venous thromboembolism. There can also be arterial involvement causing limb ischemia, myocardial infarction, and stroke. Vascular injury and skin lesion at site of injection can also occur. Consumption of platelets in thromboembolic events result in thrombocytopenia. All this usually occurs during 5th to 10th day of starting heparin therapy. So be cautious during this period. If patient develops heparin-induced thrombocytopenia, stop the heparin and switch to fondaparinux or direct thrombin inhibitor like ergotraban. Low molecular weight heparin shows cross-reactivity with heparin. It can also form complex with these antibodies, leading to similar response. So it is not an option for substitution. Other adverse events with heparin are osteopenia, alopecia, and increased liver enzymes. Now, contraindications of heparin. It should not be given in patients with bleeding disorders, history of heparin-induced thrombocytopenia, hypertension due to risk of cerebral hemorrhage, subacute bacterial endocarditis due to risk of embolism, peptic ulcer, bleeding piles, visceral carcinoma, tuberculosis, threatened abortion, recent eye or brain surgery or lumbar puncture, and advanced hepatic or renal diseases. So this was heparin. Now low molecular weight heparin and fondaparinux. For them, we will only see how they are different from heparin and from each other. First of all, what are they? Low molecular weight heparins are prepared by fractionation of heparin. Their molecular weights range from 3 kilodalton to 7 kilodalton, with mean weight of about 5 kilodalton. Various low molecular weight heparins are enoxaparin, dalteparin, raviparin, nedroparin, parnaparin, ardaparin, and tinzaparin. Fondaparinux is only pentasaccharide sequence that interact with antithrombin 3. It is a synthetic product in contrast to heparin and low molecular weight heparin which have biological origin. Next, mechanism of action. Heparin acts by two mechanisms. 1. Conformational changes in antithrombin 3, which allows inhibition of factor 10. And second, binding with clotting factors, which allows inhibition of factor 2. Inhibition of factor 2 results in some antiplatelet effect also. Low molecular weight heparin and fondaparinux act by only one mechanism, that is conformational changes in antithrombin 3. This allows inhibition of only factor 10. As they are not long enough to bind with factor 2, they cannot affect it. For same reason, they show little antiplatelet activity. Heparin increases APTT and whole blood clotting time. However, they are not affected much with low molecular weight heparin and fondaparinux. Now, pharmacokinetic profile. After subcutaneous injection, bioavailability of heparin is about 30% and that too is inconsistent. Whereas bioavailability of low molecular weight heparin is about 90% and that of fondaparinux is about 100%. And this is more consistent. Heparin binds with plasma proteins, leading to chances of heparin resistance. Whereas low molecular weight heparin and fondaparinux shows less plasma protein binding. So chances of resistance are less. Heparin is eliminated mainly by reticuloendothelial system. It is a saturable kinetic, so half-life of heparin increases with dose. It ranges from 1 to 5 hours and requires 2 to 3 times daily dosing. Elimination of other two drugs occur mainly by renal route and it is non-saturable, so their half-life is constant. Half-life of low molecular weight heparin is about 5 hours and that of fondaparinux is about 17 hours. This allows once daily regimen for both the drugs. Monitoring is required for heparin due to unpredictable response. On the other hand, these two drugs have consistent absorption, half-life and less chances of resistance. so they produce more predictable response. So monitoring is usually not required for these drugs when dose is properly calculated on body weight basis. However, monitoring should be done in patients with renal failure, pregnancy, children and obesity. Heparin therapy is usually monitored with APTT, whereas for low molecular weight heparin and fondaparinux, anti-factor 10A assay is more suitable as they do not affect APTT. Now adverse events. Heparin causes side effects like hemorrhage, heparin-induced thrombocytopenia and osteopenia. All these side effects are less with later two drugs. They cause less hemorrhage and have less chance of heparin-induced thrombocytopenia as they have low affinity for platelet factor 4 and also their smaller size reduces their immunogenicity. The chances are least with fondaparinux. They also cause less osteopenia. To protamine sulfate, heparin shows complete response, whereas low molecular weight heparin shows only partial response. Fondaparinux do not show any response at all, so it lacks specific antidote. Finally, uses. Because of favorable pharmacokinetic and adverse event profile, low molecular weight heparin and fondaparinux are preferred over heparin for most of the indications. However, in balloon angioplasty and cardiopulmonary bypass surgery, heparin is still preferred over these two drugs. That is because activation of factor 12 in these two conditions is managed better by heparin. Also, once the procedure is over, its effect can be rapidly terminated by protamine sulfate. This is not possible with later two drugs. In patients with history of heparin-induced thrombocytopenia, low molecular weight heparin cannot be used because of cross-reactivity with heparin. However, fondaparinux do not cross-react, so it can be used. That's all about heparin and its derivatives. Now let's have a summary. Heparin is a parenteral anticoagulant. It is a mixture of mucopolysaccharides with average molecular weight of about 15 kilodalton. It is strongly acidic drug. It has no intrinsic anticoagulant activity, but it facilitates action of antithrombin 3 by about 100 folds. It is done by two mechanisms. A specific pentasaccharide sequence in heparin binds with antithrombin 3 and causes conformational changes in it. This exposes its active site. Heparin also provides scaffolding for antithrombin 3 and clotting factors to come closer and interact. This additional mechanism contributes in inhibition of thrombin by heparin, and it lacks in low molecular weight heparin and fondaparinux. It prolongs APTT and whole blood clotting time, has some antiplatelet and lipemia clearing effect. Heparin is used at the beginning of anticoagulant therapy as its effects start immediately. Anticoagulants are preferred in venous conditions like deep vein thrombosis and pulmonary embolism as venous thrombi are rich in fibrin. They are also used in myocardial infarction, in unstable angina to reduce chance of infarction, rheumatic heart disease, retinal vessel thromboembolism, cardiovascular disease, disseminated intravascular coagulation, in procedures like coronary balloon angioplasty, cardiac bypass surgery, prosthetic heart valves, extracorporeal circulation like hemodialysis, etc. Heparin is preferred in pregnancy as it does not cross placenta. Now pharmacokinetics. It is not absorbed orally and intramuscular injection causes hematoma. It is given by intravenous or subcutaneous route. Subcutaneous route shows inconsistent absorption. Elimination occurs mainly by reticuloendothelial system. It is a saturable kinetic, so half-life increases with dose. Patient might show heparin resistance due to increased plasma protein binding, increased clearance, or antithrombin 3 deficiency. Because of this unpredictable profile, monitoring is required. It is usually done with APTT, which should be maintained 1.5 to 2.5 times the baseline value. Adverse events with heparin are bleeding, heparin-induced thrombocytopenia, which is an immune-mediated reaction. In this, complexes of heparin with platelet factor 4 induces antibody formation. Then they bind with platelet receptor Fc gamma 2A. It causes platelet activation and eventual thromboembolic events. It usually starts 5 to 10 days after starting the treatment, or early if patient has received heparin earlier and has already developed antibodies. In such patients, heparin should be stopped and fondaparinux or argatroban should be started. Low molecular weight heparin cross-reacts with heparin and cannot be used. Other adverse events with heparin are osteopenia, alopecia, and increased liver enzymes. Protamine sulfate is a specific antidote for heparin. It's strongly basic and neutralizes heparin. It's usually not required because of short half-life of heparin. It is used when heparin action needs to be terminated rapidly, like cardiac or vascular surgery. Contraindications of heparin are bleeding disorders, history of heparin-induced thrombocytopenia, hypertension where there is risk of cerebral hemorrhage, subacute endocarditis due to risk of embolism, peptic ulcer, bleeding piles, visceral carcinoma, tuberculosis, threatened abortion, recent eye or brain surgery or lumbar puncture, and advanced hepatic and renal diseases. Now low molecular weight heparin and fondaparinux. Low molecular weight heparin is obtained by fractionation of heparin. Its average molecular weight is about 5 kilodalton. Fondaparinux is a synthetic pentasaccharide sequence. They both act only by causing conformational changes in antithrombin 3 to inhibit factor 10. They are not long enough, so cannot bind with factor 2. They have minimal effect on APTT. They show consistent subcutaneous absorption. Elimination occurs by kidney and it is non-saturable, so half-life is consistent. Also, there are less chance of resistance with them. Monitoring is usually not required except renal failure, pregnancy, children and obesity, where it is done with anti-factor 10A assay. To protamine sulfate, low molecular weight heparin shows only partial response and fondaparinux shows no response. They have replaced heparin for most of the indications except coronary angioplasty or cardiopulmonary bypass surgery, where heparin is still preferred because of its efficacy and availability of option to terminate its action with protamine sulfate. That's it from my end. Now it's your time to speak. If you like our videos, please share them with your friends. And if you don't, comment on what improvements do you want in upcoming videos. Thanks for watching. See you in next video.